Good morning, everyone. Today I'm going to be presenting the acid code. Mr. X, 16 years old, class 10 student from Chittoor, presented with fever for 3 days with general tonic-clonic seizures or 3 episodes and low sensorium for the past 3 days. History of presenting illness. He presented with fever, which is high grade, intermittent, which was relieved on medications, which was followed by 3 episodes of general tonic-clonic seizures, with each episode lasting for 15 minutes with an interval of 30 minutes without any recovery of sensorium, and which was also associated with frothing of mouth and uprolling of eyes. And he also had persistent low sensorium after the episode of seizures and in the form of non-verbalization and decreased responsiveness. Treatment history. For the above mentioned history, he was treated in an outside hospital with anti-epileptics and antibiotics. In view of persistent low sensorium, he was referred to CMC for further evaluation and management. Past history. He was born of a normal vaginal delivery at term. He had delay in speech and walking, started walking at 2 years of age. He had generalized seizures from since he was 5 years of age and is on tablet phenytoin 100 mg BD for the past 5 years. From 5 to 14 years of age, he had one seizure episode per month. From 14 to 16 years of age, he had 5 seizure episodes per month. He was not admitted every time for seizure episodes. He was admitted this time only in view of low sensorium following seizure episodes. And he also had intellectual disability along with poor scholastic performance. Family history. He was born of a second degree consanguineous marriage and he had 4 siblings. The first pregnancy was he was actually a boy who expired at 5 years of age at delayed milestones and macrocephaly, cholohydrocephalus. Second pregnancy was a girl who expired in neonatal period, and the third pregnancy was again a girl child, and she completed undergraduation and currently married and has one normal child. And fourth pregnancy was a girl and she also had delayed developmental milestones, below average scholastic performance, and studying in 11th grade currently. And the fifth pregnancy was a patient who had delay in speech and walking and seizure episodes since 5 years of age and intellectual disability. Personal history wise, he had no addictions or normal bowel and bladder habits, and he had no normal sleep and appetite. Summary. He's a case of a 16-year-old boy known seizure episodes since 5 years of age with family history of intellectual disability, delayed developmental milestones, and neonatal death in siblings, presenting with breakthrough seizures and persistent low sensorium. Examination wise, he was drowsy, not oriented to time, place, or person. Vital signs: pulse rate was 98, BP was 110/70, saturation was 97% on room air with respiratory rate of 18. Temperature was 100.3 degree Fahrenheit on initial presentation with a GCS of 11/15, E4, V2, and M5. General examination: no pallor, icterus, cyanosis, clubbing, lymphadenopathy, and pedal edema. On CNS examination, higher mental functions, he was drowsy, not oriented to time, place, or person. Cranial nerve examinations were normal. Motor system, bulk was normal, tone, spasticity in all 4 limbs, and power was 3 by 5 as he was moving as all 4 limbs, and no involuntary movements. Sensory system, localizing pain in all dermatomes. Reflexes, superficial abdominal reflexes were present in all 4 quadrants. Deep tenon reflexes were 3 plus in bilateral biceps, triceps supinata. Knee jerk was 3 plus, and ankle, there was bilateral ankle clonus were present. Plantar reflexes showed bilateral extensor. There was no cerebellar signs. Signs of meningeal irritation were absent, and spine and skull were normal, and gait could not be assessed. Systemic examination wise, CVS was S1, S2 heard and no murmur. Respiratory system, normal vesicular blood sounds with no added sounds. Per abdomen examination, soft, non-tender, and no organomegaly was present. So summary, he's a case of a 16-year-old boy with a known seizure disorder since 5 years of age with family history of intellectual disability, delayed developmental milestones, and neonatal death in siblings, presenting with breakthrough seizures and persistent low sensorium. And on examination, he was noted to have signs of bilateral upper motor neuron corticospinal tract involvement. So differential diagnosis I consider for this case with like acute fever with general tonic-clonic seizure with significant family history and then cortical and then localizing to cortex, subcortical and corticospinal tract. My first differential which I considered for this was acute disseminated encephalomyelitis, And the second differential, since he had a significant family history, a neurometabolic disorder with a metabolic decompensation. And the third differential was mitochondrial encephalopathy, such as MELAS, which is mitochondrial encephalopathy, lactic acidosis, stroke-like syndrome. So investigation-wise, hemoglobin was 15 and WBC of 9,800. Platelet was 3,19,000 with urea create of 12 and 0.62 respectively. And he had normal electrolytes of sodium of 134, potassium of 3.5, and bicarb of 22. So dyselectrolemia causing seizures was ruled out. And total bilirubin and dallic bilirubin were 0.42 and 0.23 respectively, with total protein and albumin with 7.4 and 4.4 respectively, with AST of 16, ALT of 12, and ALP of 159. Calcium was 9.8 with and phosphorus of 4.1. Magnesium was 2.09 with GRBRS of 112, and blood culture showed no growth. And then we did CSF fluid analysis, and then where total WBC was just 2, and then RBC was 80 with polymorphoneutroph, and with the on cell count of 10, we did he had polymorphic neutrophils of 5, lymphocytes of 4, and monocytes of 1. Glucose was 83, protein was 23, with CSF culture showed no growth, and CSF viral PCR was negative. BBB was also negative for him, and with levetiracetam levels of 32.7 and phenytoins levels were more than 40, and EEG showed no epileptiform activity. Yeah. So we did an MRI brain with contrast, and findings were symmetric confluent TR hyperintensities were found in the subcortical white matter of both cerebral hemisphere with diffuse thinning of corpus callosum, with symmetrical long TR hyperintensities with mild swelling involving the caudate nucleus, globus pallidi, and lentiform nuclei. So all these features were actually suggestive of a neurometabolic condition known as L2-hydroxyglutaric aciduria. So in order to confirm the diagnosis, we sent urinary organic acid levels, which showed a highly elevated 2-hydroxyglutaric acid, by which we confirmed the diagnosis. And serum amino acid and acyl carnitine assay levels were awaited, with serum ammonia of 97 and lactase were all normal side. So the diagnosis of this patient was L2-hydroxyglutaric aciduria. And I'm just going to explain the cycle in simple terms. So dietary protein is broken down into amino acids, which takes part in urea cycle and citric acid cycle. And in citric acid cycle, alpha ketoglutarate is actually intermediate substrate. So organic acidemia. So deficiency in any enzyme involved in amino acid degradation results in accumulation of the organic acid, which then accumulates in the brain and other tissues, causing abnormalities. And there are two variants, which is classical, which is the systemic involvement, showing lactic acidemia or lactic aciduria, metabolic acidosis, ketosis or ketonuria, hyperglycemia, hyperammonemia, electrolyte alternations, and then cytopenias. Cerebral involvement will have in cerebral involvement there will be a family history of sibling death with neurodegeneration, which was seen in a patient, along with movement disorders like hypertonia. So clinical presentation wise, these patients will at the birth, at birth, the early onset, macrocephaly, motor delay, and hypotonia, failure to thrive, recurrent vomiting, and encephalopathy. And the late onset presentations, the children will have delayed motor developmental milestones, ataxia, epilepsy, and pyramidal and extrapyramidal signs. So L2-hydroxyglutaric aciduria. So it is actually a rare inherited autosomal recessive neurometabolic disorder which involves the gene L2HGDH gene located on the chromosome 14. Like I said, like in TCA cycle, there is an intermediate product is 2-alpha ketoglutarate, which is actually then a side product of L2-hydroxyglutarate is formed by L-malate dehydrogenase, which is actually a side product. And then in normal people, it is actually converted back into 2-alpha ketoglutarate by L2-hydroxyglutarate dehydrogenase. But in the patients with L2-HGDH, there is deficiency of L2-hydroxyglutarate dehydrogenase, which causes the accumulation of L2-HG, which then accumulates in the brain, CSF, plasma, and urine, and which causes the neurotoxicity. So and it actually interfere, and because of the accumulation in the it causes neurotoxicity by impaired myelination, neurodegeneration, and it also causes epilepsy. So there was a case series which was done in CMC with 10 children, which were done among a time period of 8 years by pediatric neurology department, and the diagnosis was based on elevated L2 hydroxyglutaric aciduria in present, which was present in urine. So the initial presentation for the 10 children were 5 children. Among those 5 children had recurrent febrile seizures with progressive gait ataxia in two, intellectual disability in two, and acute encephalopathy in one child. And then all the children had mild motor developmental delay, and none of them actually had adverse perinatal effects. So mean age at onset of symptom was 2.1 years, and mean age at diagnosis was 8 years. But in our patient, the diagnosis was done only at 16 years. So clinical features wise, seven out of the 10 children, 7 children had macrocephaly, 8 children had spasticity, all the children had ataxia with 8 children having seizures, 2 children having extrapyramidal involvement, and 6 children having intellectual disability, and 2 had acute metabolic crisis. So MRI changes. So MRI changes are actually typical for this case, which were like white matter involvement. So in white matter, like subcortical white matter, which will be it is involved in all the areas like frontal, temporal, parietal, and occipital, which pass the periventricular, which is typical for L2 hydroxyglutaric aciduria. There is also gray matter involvement as well, which includes dentate nucleus, caudate, putamen, involved in all cases. So thalamus was actually involved only in one case. So this is the bar graph for these findings. So evaluation wise for these patients, we send blood quantitative blood levels for amino acids, acyl carnitine, and total free carnitine, and urine we send for quantitative analysis of organic acids. And for other biochemical abnormalities to know whether it is a systemic type, we look for ketosis, ketonuria, metabolic acidosis, lactic acidosis, hypoglycemia, and hyperammonemia. So management wise for this condition, there is no disease modifying therapy, and we just support, there is only supportive management. We control the seizures with anti-epileptic medications, and dietary modifications are done for this patient in terms of low lysine diet, and then supplementation with carnitine and riboflavin. So why we give carnitine is such that carnitine actually what it does, it binds with the organic acid and it decreases the level of the toxic contents of the organic acid, which prevents the further accumulation of the acids. So in patients with this condition, they have low carnitine levels, which actually cause, because of the low carnitine levels, it increases the organic acids won't have like they can't bind to the carnitine, and it increases and it causes neurotoxicity, which causes seizures in turn. So in order for low carnitine, we just supplement the patients with carnitine. And why riboflavin is used is because like L2, like I said in the cycle, L2 hydroxyglutaric acid is converted back to alpha ketorate with the enzyme L2 hydroxyglutarate dehydrogenase, which requires a cofactor FAD. That FAD and riboflavin is actually a precursor to the riboflavin. So so giving riboflavin will increase the FAD, which in turn increases the residual activity of the enzyme and decreasing the neurotoxicity as such. So coming back to our patient, seizures were actually controlled on levetiracetam, and because of the phenytoin toxic, like since phenytoin levels were related, we stopped the phenytoin, and sensorium slowly returned back to baseline. He was supplemented with oral carnitine and riboflavin, and he was given low lysine diet. Uh, he was given physiotherapy and occupational therapy. Whole exome sequencing by NGS was the results are currently being awaited. It was done to find out the gene for this patient. Take home points for we should suspect neuro.
Just 1 minute, Joe. We have our consultant from pediatric neurology who helped us with managing, and they took over the patient after the diagnosis was made. So Dr. Uma Mohandas, I'm just inviting her to tell us a little bit more, because they deal with this much more frequently than we do.
First of all, let me thank you all for inviting me for this session. Actually, we were called upon by when most of the diagnosis was almost over. So a few key points which I would like to stress upon is, this child initially, he had an unspecified ID. We didn't have an explanation for his intellectual disability, which was there from the beginning. and his seizures were relatively early onset. But usually in this group of disorders, organic acidemias, we usually find seizures happening from early infancy itself. And mostly they have periods of metabolic crisis associated with this. With periods of metabolic crisis, they present with his flurry of seizures, extrapyramidal symptoms. That's a usual presentation that we come across. But this child, he had a very means relatively slow onset. By 5 years, he presented with history of seizures, but not evaluated anywhere. Every time he was getting seizures, he was managed with anti-seizure medicines alone. But the significant things which we noted in this child was there was a history of second degree consanguinity in the background, and there were a history of multiple sibling deaths, history of family history of ID, which all pointed that he had an underlying hereditary or genetic cause or a neurometabolic cause to start with. So, but the child was relatively stable going to school even without treatment. That's the finest part of it. So on examination, actually a few points which I felt I would like to add upon. In such organic acidurias and all, usually they have a spastic ataxic phenotype. Our child had bipyramidal signs, which was characterized by hyperreflexia, hypertonia, extensor plantar. In addition to that, he had a subtle ataxia. That time when he came in, maybe he was not able to walk, but when we made him walk, he was having a wide-based gait, but he was totally disoriented. We couldn't assess his sensorium or other cerebellar signs. So usually they present with a spastic ataxic phenotype. And in addition to that, they can also, during the course of the illness, they can have extrapyramidal symptoms, seizures, ongoing seizures, and all. So few things on, then this was the presentation. Then on examination, means while evaluating the child, in the investigation part, usually when such a neurometabolic disorder is suspected, we send for the metabolic workup. The usual metabolic workups which we send is acyl-carnitine screening, serum amino acid, urine organic acids, and so on, ammonia lactate. So for him, acyl-carnitine screening, actually the reports have come. Usually these organic acidemias, they can result in low carnitine levels, as our friend has said. So for him, carnitine levels, which can result in this low carnitine levels, are basically because of this hydroxyglutaric acid, which is excreted. It can combine with the carnitine, get excreted as glutaryl carnitine. So that's the reason for the low carnitine levels, which happens in such children. So in our child, if you see the reports, there was elevated C5 glutaryl carnitine. So that is suggestive of L2 hydroxyglutaric aciduria. And also it can happen in just glutaric aciduria even. L2 hydroxyglutaric aciduria as well as glutaric aciduria. So that was there. Apart from that, urine organic acid was showing elevated L2 hydroxyglutaric acid. So in some children, they can have, if serum amino acids can show an elevated lysine levels, but that is usually not seen in L2 hydroxyglutaric aciduria. That is usually seen in glutaric aciduria. That's a bit different entity. You might there might be a misconception whether glutaric aciduria and L2 hydroxyglutaric aciduria are the same, but there is a mild difference. Both are organic acidemias, but the clinical presentation is a bit different. Similar to that, MRI findings are also a bit different. So with L2 hydroxyglutaric aciduria, serum amino acids can show a mild lysine elevation. In such cases, maybe lysine restricted diet can be helpful. For this child, his lysine was okay. As far as I remember, it was okay. So I don't think he requires a lysine restricted diet. So then coming to the MRI findings. MRI findings, it was typical of L2 hydroxyglutaric aciduria, very typical. We won't find any further findings in this. He had typical subcortical white matter involvement with basal ganglia changes, and cerebellar dentate nuclear hyperintensities were also there. So that is all. These are the three areas which are typically affected in L2 hydroxyglutaric aciduria. Usually there will be subcortical white matter involvement. There will be basal ganglia, mainly caudate, putamen, and globus pallidus involvement with sparing of thalamus. Usually thalamus is spared, but there are studies where one or two cases are showing thalamus involvement, but usually in L2 hydroxyglutaric acidurias, thalamus is spared. And in addition to that, cerebellar dentate involvement is also seen. With the MRI findings, the DDs which we can consider in such children are similar presentation can happen in Canavan's disease. Canavan's disease usually, I don't think you will be seeing it. Usually it is happening in infancy. Infancy, they usually present with macrocephaly. Similar subcortical white matter involvement is seen in them also, but it's there is no periventricular sparing. Here, our friend told that there would be periventricular white matter sparing. Similarly, in Canavan's, you don't find this periventricular white matter sparing. And in addition to that, thalamus involvement, globus pallidus involvement can be seen in Canavan as well. Then the second differential from the MRI, which we can think about is mitochondrial cytopathies, Kearns-Sayre syndromes. Kearns-Sayre syndrome can have a similar presentation. In that case also, usually there will be brainstem involvement, basal ganglia involvement, subcortical involvement can also be there. So these are, in addition to that, they have cardiac conduction defects. And cerebellar ataxia, they will have more of cerebellar ataxia. So these are the few differentials which we consider from the MRI. So our child mostly had all the typical features of L2-hydroxyglutaric aciduria. And then the treatment, as our friend told, it's riboflavin. Treatment means more of supportive treatment. This disease has a very slow progressive course. So they relatively do remain stable for some couple of years. So just to improve the quality of life, to prevent acute attacks, we can start them on riboflavin, carnitine supplements. And usually they don't have acute metabolic crisis associated. But sometimes if they present with acute metabolic crisis, usually they can present with hemiparesis. This child, in fact, had a subtle hemiparesis when we came in and saw. So this HHE presentation during the acute metabolic crisis is seen in L2-hydroxyglutaric aciduria. So our child actually had hemiparesis, hemiconvulsions were also there. So we don't know, but blood gas and all was fine. So maybe it was not a crisis. That's it. So, thank you.
Thank you very much. It wasn't a common presentation, and I think it illustrates the importance of going back to the family history. And if you didn't get that history, you wouldn't have searched further, because he came in like seizures. And I want to just appreciate Aishwarya for doing the groundwork and a lot of what happened with the patient. Yes, you have something else to add?
Children present with macrocephaly, usually organic acidemias, and subsequently if they develop developmental delay, organic acidemias can be considered as a DD.
I think as adult physicians, at once, one group that we can say, okay, not our patient. And we don't often get to see adult patients who have these, which is why we thought we would present, and I really apologize for the amount of time taken. We'll go to the next. Thank you very much, Dr. Uma, for coming and spending the time with